Hello to everyone. It's a great pleasure having you here in this session that will be focused on epicardial and microcirculatory dysfunction. My name is Javier Escanet, and we welcome you, and we also welcome the colleagues that are attending this session online. Now, I have the privilege of having with me a distinguished number of colleagues, Vijay Kunadian, Enrique Rodriguez, Peter Ong, and Divaka Pereira. And I would like to present to you, on behalf of the team, the objectives of the session that we have set ourselves. So if we can have the first slide, yes, thank you. These are my conflicts of interest. Now, the bottom line is that we still keep using the same tool that was the only tool that was available 45 years ago to perform diagnosis in patients with coronary artery disease. At the time of Andreas Grunzig created the coronary angioplasty, generated coronary angioplasty, the coronary angiogram. And we have learned over the decades, I will say, but certainly this is a firm conviction after the evidence obtained over the last decade, that the angiogram is actually a very poor tool in depicting what is causing myocardial ischemia. In a way, it has also been the cause of having a culture of ischemic heart disease that is largely stenosis-centered, and that has ignored that ischemia may come from other compartments of the coronary circulation, like the microvasculature. So in this, just to put this together, you can see here this paper by Manesh Patel that basically was putting together these nearly 400,000 patients in the US undergoing coronary angiography, and where you can see that even in those that have a positive non-invasive test, even if those that have angina, in 45% of them you do not document obstructive coronary artery disease. Now, we have new tools that are available to us in the cath lab that allow us to interrogate both compartments. And this is the one that allows us simultaneously to obtain information about coronary stenosis, like a conventional pressure guide wire. But in addition, as you can see in this video, allow us also to get information on the status of the coronary microcirculation. And this is using the principle of thermodilution, which combined with pressure allow us to calculate not only coronary flow reserve, the dynamicity of coronary microcirculation, but also the resistance of the microcirculation, which speaks about, an impairment in conductance caused by a number of diseases. Now, given the simplicity of this, we are at the verge of doing an entirely different diagnosis of ischemic heart disease in the cath lab. And actually, what you are seeing here is already being tested in an ongoing study that has included 200 patients. It's called the 8-ANGIO. 8 stands for Advanced Interventional Diagnosis or Advanced Invasive Diagnosis. It's taking the opportunity at the time that you are in the cath lab to quickly identify those that have overt severe stenosis and understand that that's probably the cause of myocardial ischemia. If you have intermediate stenosis, to interrogate and to understand if these are flow limiting or not. And if they are no flow limiting, like in the case of having coronary arteries without stenosis at all, going for vascular functional tests that will inform on whether there is a problem in the coronary microcirculation, a problem in the coronary vessels, either of vasomotor origin or structural origin. And the value of this approach that today you're going to be you are going to understand is that, of course, it can improve patient comfort, speed up the diagnostic workflow, reduce risk associated to repeat vascular access in making multiple studies, and saving cath lab time and procedural costs. So, with this in mind, the learning objectives of the session today are to understand the value of intravascular physiology to guide your management of epicardial disease in the first place, something that has been there already for some time, but also to understand how a stepwise physiological approach, similar to the one that I just shared with you, can identify the cause of angina in your patient with or without obstructive disease, and also to understand how finding the cause of angina is a key step in deciding on the treatment plan. And for that, we have, in the first place, the concurrence of Enrique Gutiérrez from Hospital Gregorio Marañón in Madrid. He's going to share with us a specific case that I'm sure that is going to be very interesting. Enrique, thank you. Thank you.
While Enrique is coming, please also, we have dedicated time for audience discussion. So please present your questions to us, which we will seek to answer.
So I'm going to share with you a case of epicardial coronary artery disease, and we'll see what we did with this patient with quite a complex disease. So I have these disclosures. This is a 72-year-old male. He has all the cardiovascular risk factors: hypertension, diabetes, hyperlipidemia, and he's an active smoker. And he presented with angina and dyspnea on moderate exertion over the last months. He was referred to the outpatient clinic, but because the angina seemed to be quite severe, he was referred then to the emergency department for an urgent catheterization. The ECG showed nothing but a right bundle branch block and negative T waves in corresponding leads. And the blood tests were normal, including troponin, of course. The echo showed normal left ventricular ejection fraction, and there were no regional abnormalities. And he was currently treated with atorvastatin, antidiabetics, and olmesartan. So we did a coronary angiogram, and this is what we saw. So as you can see, there's mild atherosclerosis in the left main, and the first thing that you see is in the distal circumflex this intermediate lesion, which affects this second marginal branch, which is of good size. Here in the spider view, you can see more or less the same thing, but you can also appreciate there's a severe lesion in the proximal LAD. There's also a lot of calcium in the LAD especially. And here in the cranial views, you can see both the tight lesion in the proximal LAD and the lesion in the circumflex, which in this view appears to be severe, although I can realize it's difficult to see on the screen. And then finally, on the right coronary artery, there's a long lesion, which at some point seems to be like 60 to 70%, something like that. Okay. So, in summary, we have a diabetic patient. He has chronic exertional angina, and he has three-vessel disease, or at least he has lesions in all three vessels. Well, there's these possibilities for treatment. We could do medical therapy, but he seems to be pretty symptomatic. We could do bypass surgery, and I think it would be reasonable, or we could do PCI. If it's feasible with a low risk. So we did syntax score. Syntax score is anatomical syntax score is 14, and syntax 2 score, as you can see, shows more or less equipoise between PCI and CABG. So we could decide one thing or the other.
So Enrique, let me stop at this point for a second because it's such an interesting case. And let me ask my friend Divaka, what will be the attitude of in your hospital with someone who has diabetes, triple vessel disease, and that you have this index, which I think is a very important one, syntax 2, but that when I bring it to my surgeons, we always have some conversation about it. What would be your...
Yeah, so it's a really interesting case. So this could go one of two ways. Firstly, we as cardiologists may never hear about this patient because it could go from a referring hospital where the diagnostic angiogram was done straight to the surgeons and they have surgery. Or it could, if the question is raised as to whether this disease is significant, which of the two modalities should we pursue, then it will come to a heart team decision. And if it were to come to a heart team, then it depends on whether the team feel that the angiogram is sufficient. If they feel the angiogram is sufficient, then they'll probably go to the patient and say, we can give you equivalent revascularization if revasc is what you want to do. And the choice will be made that way.
Vijay, let us know if there is any colleague that is joining online or using the app from the audience that is bringing any question.
Yeah, sure. There are some questions relating microvascular dysfunction, but we'll come to that in the second half of our...
So, Peter,
yeah, please do send us your questions.
In a snappy way, what the surgeons and your colleagues in the hospital will say about this patient.
Well, I personally would like to have more evidence for myocardial ischemia, because, okay, the LAD lesion looks pretty narrow. I would agree on that. But the rest, to me, doesn't look convincing for myocardial ischemia. So I would like to have more information.
Okay, let me ask you one question. How many times the surgeons in your hospitals ask you, have you performed FFR?
They're beginning to ask it more and more because they're getting used to having this available when they're presented to patient. So in my hospital,
In your place?
Yeah, since we started working together in the mornings, we introduced the concept to them quite frequently, and now they know about it.
That's great. That's absolutely great. So probably we can, Vijay, we can...
There's one question. We're not surgeons, but I'll just bring it in really quickly. Is there published evidence behind the strategy of physiological assessment of multivessel disease prior to bypass? And should the surgeons bypass only the FFR, IFR significant lesion?
This is a very good point.
Good question. I mean, there isn't a randomized trial, but the observational data are really interesting, suggesting that the patency of grafts is affected by your physiology at baseline, and not getting into values necessarily, but the more physiologically significant, the greater the long-term patency.
Yeah.
And I think that something that we learned also from these studies that perhaps may interest to the colleagues is that in performing follow-up, we learned that it's true that, when you have lesions that are not significant, a number of grafts occlude, but it is exceptional that they have any problem. Can you imagine if that would be a stent that gets a stent thrombosis? So it's a big difference between putting a graft in a vessel with a stenosis that is non-significant,
Yep.
the consequences of graft failure are nothing, than having the consequences of a stent failure.
Yeah, only that there is, again, some risk that you could accelerate the progression of minor coronary disease, minor atheroma in your native coronary arteries.
Vessel,
So,
Okay, we can go back to Enrique.
Okay, so in our institution is the same. The patient could have gone to the heart team, but sometimes we want to make sure that we're doing the most precise recommendations. So what we decided was to do FFR on the intermediate lesions that Dr. Ong was referring to. And this is the right coronary artery. As you can see, this is long disease, and at this point, it seems quite tight. So this is an FFR done with intravenous perfusion of adenosine. And we did it like this because we wanted to do pullback pressure tracing to see if there was a pressure step up along the artery. So as you can see, the initial FFR that we have is 0.85. That means this artery is not ischemic. This territory is not ischemic. Then we did the pullback, and we see quite a brisk step up in pressure, which means that the disease that we're seeing is predominantly focal. Okay, but in any case, it does not need revascularization, at least with the current evidence. Then we did the same at the distal circumflex. But in this case, this is a bolus FFR. So you don't always have to do a perfusion of adenosine. If you have a patient who's asthmatic, or if you want to do it quickly, you can do a bolus of adenosine. And in this case, this is what we did. And we have an FFR of 0.86, also non-ischemic. All right. And then at last, because we had the wire, we also did the same in the LAD. Of course, you don't need to do FFR in this type of lesion. It's quite clearly an ischemic lesion. But as you can see here, we have a very low FFR. This is one of the lowest I've seen, 0.46, which means very ischemic lesion. So now at this point, instead of 3-vessel disease, from a functional point of view, we have 1-vessel disease. It's a proximal LAD. And if we do, again, a syntax score 2, we can see that the risk of PCI seems to be lower than the risk of CABG. Probably a diabetic patient with proximal calcified LAD, it's not unreasonable to consider a bypass, but I think many of us would consider PCI. Maybe we can have a show of hands who would refer at this point the patient for surgery. Okay.
So let's make it the digital way.
Okay. Yeah.
The analog way. Who will be for first going, now that you have this information, going for PCI in this particular patient? I think that I would personally. and who will be still considering that surgery is a good option. That's interesting because in a way what you are saying is what the syntax score 2 is telling you. I mean, it's taking into account that perhaps, because it's a proximal LAD, it's a large vessel, surgery is by no means a bad option, something that you should consider and you should take into account. But I think that perhaps we can go now to the interactive screen. I will do it this time. But I think that this is the anatomy of the patients that we had before. And I think that the most interesting thing is that we've seen that this stenosis that we thought that it was particularly significant turned to be with FFR more than 0.80. Is that correct? This one happened the same, and it was at the end of the day only this one. I think that this is the message that we also obtained, in the syntax 2 study, the transformative effect of having multi-vessel disease, triple vessel disease, to a situation where you have this. And overall, in the syntax 2 study, about 1/3 of the stenosis that were present in these patients with triple vessel disease, that in the original syntax trial were systematically treated with stents, they were spared. And in many cases, like in this case that you are showing us, Enrique, we also found that triple vessel disease got reconverted to a single vessel disease at the end, which I think is very, very interesting message.
Right. So that was our take on this case. So what we decided to do was to single vessel PCI. Of course, there's a lot of calcium, so we used the same wire. We used the pressure wire X for PCI. We did predilation with a 2.5, and then we used the cutting balloon because of the calcium, and implanted a 3.0 stent that was optimized proximally to 3.25. This is the final angiographic result, and there's one thing that's interesting here. There's mild stenosis in the left main, and also there's mild distal stenosis in the LAD. So for this reason, we did post PCI FFR just to check that the functional result was satisfactory, that we had gained points of FFR in this patient. And as you can see, we have an FFR, a post PCI FFR of 0.90, which indicates overall good prognosis. There's many studies. Everyone has a different cutoff point, but 0.90 is a pretty good point. And then we have a pullback which shows that there's not a risk step up of pressure in the stent, which is also good because an under-expanded stent could give you a signal in the pressure tracing. The patient was discharged with anti-diabetics, aspirin, ticagrelor because he's diabetic, high risk for ischemic events, atorvastatin and bisoprolol. And on follow-up, he's been asymptomatic for angina so far. So I conclude that the FFR allowed us to confirm ischemia in the LAD territory, which was evident, but still, and to rule out ischemia in the other two territories. And this allowed us to downgrade the anatomy of the patient from 3 vessel to 1 vessel, and to avoid bypass and just treat with a single stent in the LAD. Also, the post-PCI results are good, which indicate good prognosis, and indicate also that the residual atherosclerosis in the LAD does not need treatment. And that's all. Thank you.
There are some questions coming through. Either Peter or Devaka could take that question. It's a practical one. Are we okay just doing IFR for these patients? I mean, obviously Enrique did FFR. And the question is, do we need to repeat it with an FFR? With adenosine?
It's a good question. I was fairly sure that this question would come up during the session at some point. And there are good data to support both hyperemic and non-hyperemic measurements. And I think every cath lab needs to have a study flow. And what I would tend to do, especially in multi-vessel cases, is to first get the non-hyperemic measurement. And if it's clearly a non-significant lesion or a clearly significant one, then you don't need to give adenosine. That tends to make the study, the procedure go more smoothly. So I might have done 1 or 2 vessels with non-hyperemic in this case, and if there was a real need to establish the significance if in a sort of gray zone area, then I would have used FFR. That's my own practice.
I've done the same in situations where you're looking at the lesion and then you do the IFR. Oh, I'm not sure. Okay, let me just give some adenosine and double check. It's more for your reassurance as to exactly whether we need to proceed or whether we, or just stop there. So Peter, go ahead, please.
Just to add on that, there is a discordance in FFR and non-hyperemic pressure measurements in about 15% of cases. And that depends also on lesion morphology. And this is important to recognize when assessing such patients, because if the non-hyperemic pressure index is borderline and you do the FFR and it clearly goes into one direction, well, then it obviously helps you in decision making. But sometimes it can be a discordant result, and then you have to closely look at the lesion morphology and then perhaps also consider using additional measurements such as the coronary flow reserve, for example.
There's another question that's come through at Lucas, Xavier and Devaka. How do you get pressure tracing using the Coraventus system?
Well, the Coraventus system is set up to give us pressure tracings. Do they mean flow or pressure? Because once you press your go to your Coraventus screen, it's set up for pressure. If you want to then go on and do flow, then you have to go into the thermodilution, bolus thermodilution mode. Have I?
Yeah, I think that's probably the question. What's the difference between a straightforward FFR wire adenosine and a Coraventus system?
It's a matter of switching to the system and then doing a set of bolus thermodilution measurements at rest, inducing hyperemia, and then doing the same again. So you get the flow reserve that you mentioned, Peter.
Yeah, probably the colleague is also alluding to the fact that you have access to both hyperemic and non-hyperemic indexes. It's something
you do.
So you have on the one hand FFR, but you also have the possibility of measuring RFR, which is basically whole cycle instantaneous index. It's looking to the location within the cardiac cycle where the PD value is the lowest, which typically is in the diastole. But
it's just different settings that you can choose from the Coraventus software. Once it is open, you can say, okay, I want to do an FFR, or you say I go for RFR, or you say, okay, I want to have CFR, IMR, and then you just choose it and then you can start.
And it is worth using that full menu of options, including pullback, because when you save it using those options, it's much easier to review it afterwards than if you don't, if you just do it on in the one mode.
Yeah, there are lots of discussions around bypass, which you've already touched. And as you pointed out, Javier, the big deal about using physiology here, you've just prevented from an open heart surgery into a single vessel PCI, which is exactly what this patient, and that's where the benefit of physiology. And people are bringing in the FAME-3 study here. So based on the FAME-3 study, this patient might have been referred with a 3-vessel bypass surgery. What are your comments?
Okay. Yeah. I think that is a fair point. In truth, we were speaking before about do the bypass get occluded if the lesion is not ischemic, and there's observational data, but not trials about that. But for me, the question is, does this territory need revascularization? Because it doesn't matter if the bypass is going to remain patent or not, if it wasn't needed in the first place. So I think that's fair rationale for what we did.
Yeah.
Vijay, may I make a quick comment about that? A beautiful illustration of how to use physiology to make the diagnosis and also to check your final result, Enrique. So thank you. One, I was thinking about the bypass versus PCI question. I know one of you raised your hands for bypass. One step that I might have added, which might have helped, would have been to do a pullback before we did any measurements in the LAD and the diffuseness of the disease, because there appeared to be some mid-course disease. The diffuseness of the disease may have influenced whether I went towards a single Lima graft or PCI. We know because you did the post-PCI measurement that actually it was all in the proximal vessel. But I think it might be worth doing it beforehand.
Well, something that perhaps is worth opening the conversation a bit. I mean, interestingly, FAME3 was designed at the same time that Syntax-2. We were exactly at the same time designing the study. And I think that we took different directions. FAME3 say what makes the difference is the physiology. And Syntax-2 say what makes the difference is the combined use of physiology, imaging, right stents, opening the CTOs, combining best practices. And I think that personally is what I miss in FAME3. Such a low use of intracoronary imaging is something that I think that makes a huge difference. And I think that at this point, of course, we all believe that physiology is a very important part of our practice, but we know that it is not the only best practice that we have there, that we have to combine with others.
It's a really important point. I know we're in a physiology session, but it's just one tool that we have available to us. And we should use all of it in terms of making the diagnosis, but tools and resources also in terms of delivering good PCI.
Yeah, even with the physiological assessment, we've talked about FFR. In Enrique's case, we have IFR and then RFR. And there is a question coming from our audience. What if there is a discordance between RFR and FFR? Which one do you believe to manage your patients? Any experience with that?
Well, I think that there are many. There is a common denominator, which is flow. Obviously. So resting indexes are more sensitive to flow. Remember that FFR is like you are examining an eye after putting atropine, the microvasculature is paralyzed, so to speak. When you're making a resting index, you have a normal functional microcirculation, which is responding to the effect that you have of restenosis, etc. And probably that is why consistently all the studies that have compared FFR and non-hyperemic indexes with coronary flow reserve find a better correlation between coronary flow reserve and non-hyperemic. And this is one aspect. The second one is that FFR is very sensitive to turbulence. That's why you increase flow. You increase flow to generate lots of turbulence, and then you identify the stenosis. IFR is more sensitive to friction. And this is why one of the major determinants, and it's very timely because now we are very interested about focal and diffuse disease, one of the major reasons for discrepancy between FFR and IFR is the presence or not of diffuse disease. If you have diffuse disease, you tend to have more FFR negative, IFR positive results than when you have FFR. If you have a very focal disease, you tend to have more FFR positive. But does it make sense? You probably can complement this with your own experience and your knowledge.
Yes, absolutely. And I would add on this that the defined flow study has looked at the outcome of patients with an epicardial stenosis where the combined assessment of FFR and CFR was done, and they challenged the provocative concept only to stent those lesions where FFR and CFR were both abnormal. So what you're saying is, in my opinion, completely right. If the CFR is normal, but the FFR is abnormal, then one could actually say there is no need to do PCI. And this is why when we do a non-hyperemic pressure measurement, and this is abnormal, and it fits well with the CFR, and that's also abnormal, then we tend to go for the intervention. But if the CFR is okay, then the microcirculation is still working, and that's a very strong outcome indicator.
So I think that, Vijay, this takes us very nicely to the second half of the session that has to do more with microvascular dysfunction and microvascular function. So, Peter, can you illustrate us about that with a case?
Yes, thanks very much. So I'll present the second case in this INOCA in 2023 evidence into practice. session. It is a 69-year-old gentleman. He presents with chest pain of unknown origin, starting approximately 6 months ago. The chest pain occurs on exertion as well as at rest and also during nighttime. There's also shortness of breath on exertion, NYHA class 2. And he has hypertension, an LDL of 125 milligram per deciliter without any treatment. And he's a past smoker with approximately 30 pack years. He has had several investigations because of his symptoms, including gastroscopy without any abnormalities. His echocardiography shows normal LV function with only mild mitral and tricuspid regurgitation. He has septal hypertrophy because of his hypertension. And his exercise stress test was stopped at 125 watts without any relevant findings, but he was not able to increase his heart rate to the number needed. He's recently diagnosed with paroxysmal atrial fibrillation, and this is why he has the current medication shown on the right-hand side, including candecetan, amlodipine, bisoprolol, and rivaroxaban. This is the resting ECG, and I'd like to point out that there is some T-wave inversion in leads 1 and AVL. This is probably something that you would not consider as abnormal, or you would consider it as abnormal. We often see it in these patients, especially in AVL, that there is a negative T-wave. And this is also something that is dynamic and important for the history. So we evaluated the patient, and the question was how to proceed. He had an exercise stress test, 69 years old with risk factors and symptoms. And the decision was made to go for invasive coronary angiography. And you can see here the images of the right coronary artery. I think you can see that there is some epicardial atherosclerosis, especially here in the distal side branches. I don't know if...
With the cursor is better. So.
Yeah, I'll use the mouse, that's fine.
Yeah.
And then also here on the right-hand side, you see that there's actually no relevant epicardial stenosis. And then you can see here the images of the left coronary artery. The LAD flow is a little bit slow. There is also epicardial disease, but nothing that is really looking relevant. And I think you have had many of these cases yourselves, patients who are sent for angiography, suspected epicardial disease, and you don't find any relevant lesion. And so then the question is how to proceed with these patients, what to do next. Is it a case where you just say, okay, I do secondary prevention for some atherosclerosis, or I do something else to investigate the cause of the symptoms?
And probably you could ask, what is next and when? Probably that's another question.
That's also a very important question.
Raise of hands again.
Yes, please.
Yeah, go for it.
Yeah. So who of you, just by a show of hands, would just stop here and say, no relevant stenosis, secondary prevention, we're done? Just in a routine, okay? Maybe 30% or so? And is there somebody in the audience who would, at this point, do some additional investigations or routinely? Yes. And who of the few who would do it, would you do it directly, ad hoc? Yes?
Okay. Yeah.
Okay, yeah, there are actually some people nodding, yeah. I think it's very important that the cardiologist decided to go for invasive angiography because there was a suspicion for epicardial disease or microvascular disease. And if you don't find any relevant epicardial stenosis, then you should go for these additional investigations. And in this case, it was done as an ad hoc procedure. That means we've done the invasive angiography, there is no epicardial stenosis, and we directly move on with the so-called invasive diagnostic procedure. This is shown here on the slide, and it involves the assessment of vasoconstriction using acetylcholine in a stepwise approach with escalating doses. And this is followed by the assessment of the vasodilatory part using adenosine, where the coronary flow reserve and the index of microvascular resistance is assessed. So this was also done in this patient. And here you can see the left coronary artery at the third dose of acetylcholine. This is 100 microgram. You can see here some subtle ST segment depression in the inferior leads. And the patient had a production of the chest pain that he often had during nighttime at rest. And then we injected nitroglycerin, and the ECG went back to normal. The left artery is okay. And here on this ECG, you can see that the T wave in one, and not AVL is probably not so easy to see, but in one, it's positive again. So there is a dynamic change in the T waves. And because of the reproduction of the patient's symptoms and the dynamic ECG changes, we made the diagnosis of coronary microvascular spasm. But that was not all that we did. The adenosine testing was the next that we performed. And as Professor Eskenet already explained, we placed the pressure wire X in the LAD. We measured the resting transit time with the bolus injection of 3 milliliters of saline. And then the hyperemia is induced, and we measure the hyperemic transit time. This approach is done with the Coraventa system, and you can see here that the cath CMD algorithm has been developed to guide you during these examinations. Here, I just quickly explain where these letters stand for: catheter engagement, advancement of the wire, transit time at rest, and then hyperemic transit time. The hyperemia can be induced, as Dr. Gutierrez said, with the intravenous adenosine, but also intracoronary. And we prefer intracoronary because it barely has any side effects and it is a bit faster. So here you can see the results of the different measurements. This is the resting transit time, the 3 measurements, and then the hyperemic transit time with the 3 measurements. And this brings us to the interpretation of the results. The coronary flow reserve was 1.9, sorry. The IMR was 25. And we can see that there was epicardial disease, but nothing relevant with an FFR of 0.85. So this was very important in establishing the second diagnosis in this patient with the CAS-CMD algorithm, which was impaired coronary flow reserve and elevated microvascular resistance. Just to remind you that here on the left-hand side, the CMD stands for coronary flow reserve, and less than 2.5 is considered abnormal, although there is a gray zone between 2.0 and 2.4. The microvascular resistance with an IMR of equal or greater than 25 is the cutoff, and then making the diagnosis to change the treatment of the patient. This is what we did. We started with an exercise program. There's a very nice study from Norway published in European Heart Journal Open only 2 weeks ago, showing that in these patients an intensified exercise program really works. Rosuvastatin was started. The bisoprolol was increased because of the low CFR. We wanted to target the diastole so that the perfusion increases. We started with ranolazine because of the microvascular dysfunction in general that we found, and the patient improved after 3 months of follow-up. So I stop here, and this are just some summary remarks, and I thank you for the attention. Thank you.
Fantastic. So I think that's great. Vijay, I think that we had prepared here a graph that is included in the document that you shared.
Yes.
And perhaps you could guide us through it.
So obviously it was really surprising to me to see that many would not go any further. And the case that presented by Peter clearly shows that there's more to what meets the eye is a saying, isn't there? So obviously the coronary arteries, the epicardial arteries, there wasn't very much there. But then when you actually went into investigating further, we're using acetylcholine and subsequently adenosine, we found there was element of microvascular spasm as well as coronary microvascular dysfunction. Just imagine if you're not treating those patients. He's going to come back to your clinic over and over again with the same symptoms. And also we are learning that these patients actually have adverse outcomes, including mortality and recurrent myocardial infarction and other psychological symptoms as well. That's why it's absolutely so important. Before we rule out as a non-cardiac chest pain, we've actually looked at our patients a bit more in detail to come to the diagnosis of, is this macrovascular spasm? So often the epicardial vessel spasm, you do the angiogram and you give nitrate and the vessel expands. And I have had cases where severe constriction and it's very obvious and you give nitrate. And in those situations, I don't usually bother to prove that it is epicardial spasm with acetylcholine. You've got the diagnosis right there. And then you're giving medications to treat the epicardial vessel. And of course, the microvascular spasm, as in the case of Peter's, where you don't actually see any obvious changes on the epicardial vessel, but you might see changes on the ECG or the patient's symptoms, for example. And just because we don't see anything on the epicardial vessel doesn't mean that the patient does not have any issues with the microvascular. So it's demonstrating that this patient has microvascular spasm or abnormal vasoconstriction, and I need to do something about it. And of course, the other endotype is what we call, as we have described in our consensus document, is the coronary microvascular dysfunction, is abnormal vasodilatation, which responds to ranolazine in Peter's patient's case, or even beta blockers. Obviously, that's the one where, obviously, we need to rule out the epicardial stenosis, and that's where we provided the algorithm that you do an FFR, exactly like how Enrique did in his case. And if the FFR is greater than 0.8, and we discuss about the Coraventus system, there are certain systems that allows you to measure your microvascular function straight away. And the most common one is the CFR. And that, of course, requires adenosine. That was the algorithm that Peter showed nicely. You can either use intracoronary or continuous, as long as you demonstrate the coronary flow reserve. And according to our document, we've given a value of less than 2. So if you identify coronary flow reserve of less than 2, then you know that your patient has problems in the microvasculature. And of course, again, elevated IMR is also suggestive of coronary microvascular dysfunction. So we have a number of tools, not just stopping without doing anything and saying non-cardiac chest pain is probably in this day and age not the right thing to do. We have to go further because we are discussing a case of chronic coronary syndrome, and if you look at the number of angiogram either on CT or invasive coronary angiography, up to 50 to 70% of patients will have the sort of angiogram that Peter showed, not a lot happening in the epicardial visible vessels on angiogram or CT. And those are then history taking the history. Yeah, I'm convinced that this patient has symptoms. I'm going to look further. It's taking that next step. And there are, of course, other modalities. Tomorrow morning at 10:30 in the same room, we're having another major session focused on INOCA and ANOCA alone. And you will see some colleagues presenting non-invasive CFR assessment. Again, even it's thinking about it to come to the endotype diagnosis. Is this epicardial, I don't know how epicardial vasospastic angina? For me, that's one of the easiest thing with the easiest medication that you have available. Microvascular angina, of course, you need the provocation with adenosine to demonstrate that. And and a lot of patients, and again, a lot of studies coming from our colleagues in the Netherlands shows it's not just, I think your patient has both, didn't he? Problems with abnormal vasoconstriction and abnormal vasodilatation. So that endotype, again, the mixed we're seeing that there is a increased occurrence. So why do we have to bother with all of these things? Is to make sure that there are, and we haven't quite got to the bottom of the appropriate medical therapy in these patients, but with what we have, we are able to fine-tune the medication so that we can relieve their symptoms.
Fantastic, yeah, very good. So while we check for questions from the colleagues in the audience, let's get some reactions to the case. Divaka, it's a very interesting case, of course.
Yeah, no, very nice case, Peter. And I hope that we've convinced those of you who didn't put your hands up that actually it is really important that we get a diagnosis. We were saying, someone comes to the cath lab to exclude epicardial disease. Someone comes to the cath lab because we think they've got an ischemic substrate for their symptoms, and they can't leave the cath lab without a diagnosis. And doing an angiogram alone doesn't allow you to make that diagnosis. So I think it is really important to do. In our cath labs in my institution, they would have had very much the same testing, perhaps in a slightly different order, and that's something that we could discuss. Because I think CFR and that microvascular assessment diagnosis is probably the most important one. I tend to do my adenosine-based measurements with nitrates beforehand, up front, and then provided the acetylcholine testing is more than 15 minutes after that nitrate infusion, I'm pretty happy that the acetylcholine measurements are okay. And the reason I do that is because if we are going to measure CFR and you've induced ischemia with your acetylcholine, you probably will never have a true resting state for the rest of the case thereafter.
Yeah, thank you for bringing this up. I think it's an important aspect, the sequence of the testing, acetylcholine first and then adenosine or vice versa. The point for acetylcholine first was always the point of the nitrates, how long do they actually work in the arteries, and is it 10 minutes, is it 15 minutes, or is the effect gone by the time when you do the acetylcholine after the adenosine? And the other aspect is what you mentioned, that if you do induce spasm, does the flow really go back to baseline? And it was also in development in our institution. We used to do acetylcholine in the first place, like until a couple of years ago, because of the higher likelihood in getting an abnormal result. If you look at the studies who did both, then it's probably 70% abnormal acetylcholine testing result, and then 20 to 30% abnormal CFR-IMR result. And if you want to have a diagnosis, then if you do it in the first place, the acetylcholine, then you have something in your hand and you can start treating it, and you probably don't need to do the additional wire-based assessments. But of course, prognosis is also an important issue, and that actually brings in the CFR and the IMR, because that has a stronger prognostic information than the acetylcholine. Yes.
So Peter, before we ask Enrique, do your surgeons ask you about what was the FFR? Now I ask you, do the clinical cardiologist ask you what was the CFR?
Not many, but they start to like the concept, actually, because we all know these patients who come back again and again, and sometimes we don't want to see them anymore because they presented so often. And if you actually can make a diagnosis and try to treat them and to improve their quality of life, because this is the main goal, and also to address the psychological aspects of these patients. There's this study out there from Gulati in this year published International Journal of Cardiology. A patient needs 4 consultant appointments in different medical areas to actually have the diagnosis of vasomotor dysfunction. And it takes on average 3.5 years. So there is still a lot to do.
So there's a few questions coming through from the audience, Xavier. Perhaps we could answer them while we are on the same section of doing the test. Do anti-anginals need to be discontinued before microvascular assessment? Peter, there is a question from our colleague in the audience.
Yes, ideally they should be discontinued 48 hours before. But in practice, we do 24-hour before. And this is from our clinical experience. It's completely fine. Yeah.
So, Divakar, there are patients that come in with positive ischemia tests, non-invasively done, and you do all of the CMD assessment and it's all negative. And it could be the other way around. Patient have ongoing symptoms, but no ischemia being demonstrated. And you bring them to the cath lab and you find CFR of 1.9, IMR of 40 or something like that. So they come under the ANOCA category. So could you, talk us through how we deal with that in daily practice? More so to how not to miss these patients. Just because they don't have ischemia demonstrated, that doesn't mean that they don't have microvascular problem.
Yeah, so patients often have some sort of non-invasive test before they come. Usually the pathway in the UK anyway, as you know, is to have a CT first. So the non-invasive test may have been an anatomical one, but occasionally they would have had a functional one. It's my experience that if the anatomical test is abnormal, be that an exercise tolerance test or a stress perfusion cardiac MR, then you're very, very likely to find a vasomotor abnormality. But the reverse is not true. Sometimes there are patients who have normal non-invasive tests in whom you find an abnormality. So the non-invasive testing has good specificity, but not very good sensitivity. And I think that's the real value. If they get to the cath lab, then there really is no reason not to go on and get the full diagnostic set. And Peter, you spoke about the time taken to establish a diagnosis, but the reverse is also true. The time taken during which there's diagnostic uncertainty, and some of these patients may actually have all of these tests being normal, and then you can remove that, from the menu of items. So I think that they're both very useful. The more difficult question. So I've said if they come to the cath lab, there's no reason not to do the testing. The patients who haven't come to the cath lab but have a normal CT, no obstructed coronary arteries on the CT, that is a conundrum that we have to, as a community, address, because these patients far outnumber those who come to the cath lab and are found to have unobstructed coronary arteries. What do we do? Do we bring them to the cath lab and do invasive testing, or do we use non-invasive testing? If so, what is the best test to do?
Sure. And it's something in this direction, something that perhaps is good to share with the colleagues, is the fact that influenced by the paradigm that what causes ischemia is obstruction in the coronary arteries, the tests that we use, non-invasive tests that we use to detect ischemia, I'm not talking about imaging, but radionuclide or radical tests or stress echocardiography, there are tests that are looking for a particular type of ischemia. The ischemia that is caused by an obstruction of vessel, and that translates into heterogeneity in radionuclide uptake or heterogeneity in wall motion. And this is not the type of ischemia that sometimes these patients have. So it is the point is that a normal stress echocardiogram does not rule out, isn't it, that there may be microvascular dysfunction. Sometimes a humble EKG exercise test is more revealing that something is wrong than these, more sophisticated techniques, I believe.
I agree, because a lot of the tests that we do, stress echo, so radionuclide tests, rely on heterogeneity, because you generally have one or two vessel disease, and there's a territory that is well perfused, and you look at the difference between the two. That's not of much use, because CMD, microvascular dysfunction, it affects all territories. So even perfusion CMR, which has a higher resolution, is still prone to the same issues of there being widespread abnormalities. And it may be that the good old exercise test is something that we need to start thinking about. Or if you're going to use techniques like perfusion CMR, to actually use quantitative perfusion rather than visually looking at what's different.
Yeah, I think for me the message is that even if they come and have no ischemia detected, and if there are ongoing symptoms, we are bound to investigate them further.
Sure.
Because there are studies, which again we'll discuss again in detail, that these patients do end up with vasomotor disorder or coronary microvascular dysfunction.
Please remember that there are microphones in the room, so you can use the app, but if you feel more comfortable just making a question, please stand up and use the microphones.
Yeah. I think the next question is for Peter. So again, we touched on this already. What are the evidences for medical management of coronary microvascular dysfunction?
Well, first the diagnosis, then the treatment. So if we follow the recommendations and we are able to distinguish the different endotypes, then we have the randomized iCoreMica study, the CoreMica, sorry, that has shown that the targeted treatment based on the endotype actually improves symptoms and quality of life. And very broadly, that means if the CFR is reduced or there is evidence of increased microvascular resistance, the first-line treatment would be a beta blocker, and then you could add ivabradine if you want, and then second-line treatments are ranelozine, trimetazidine, and so on. And for those with an abnormal acetylcholine test where coronary spasm is the main problem, of course, you would use calcium channel blockers, long-acting nitrates, or nicorandil. And then there are different patients with refractory symptoms with some special indications, but this is the first approach, and we have randomized studies showing that this improves the outcome. This is why it is a Class 2A recommendation in the current CCS guidelines.
Can I say something about this?
Sure.
So I often get asked, well, why can I do empirical therapy? If something doesn't work, I'll just change to the other thing. The thing about treatments is that they often fail. And if you don't know what the patient has, then you don't know if you have to increase the dose of beta blocker or if you have to change it for another thing, and if the beta blocker is actually harming the patient. So I don't think it's as simple as I'll just try one thing and then the other. You're taking years away from the patient when they could be feeling well instead of bad.
Yeah, I think that's completely right. And it's also important to stress that a lot of this treatment efforts are trial and error at the moment, still. And there are studies ongoing, actually 3 big trials at the moment, where the different treatments are evaluated, and probably in the next 2 years we will know what is an even better treatment algorithm for the different endotypes.
There are lots of questions coming through, Javier. I think perhaps colleagues can come along
We still
afterwards.
have a couple of minutes.
We still have time, so...
It's better to have a very short wrap-up and take questions from the colleagues.
Does CMD predict future obstructive disease, given the association with risk factors? So is future investigation inevitable rather than discharge with a final diagnosis? So,
I don't know of longitudinal studies where people have repeatedly assessed the coronary circulation, but if we take it back to major adverse events, which is the patient-centric outcome of importance, we know that an abnormal CFR predicts not only a higher risk of cardiovascular events or cardiac events, which is admission with angina, acute coronary syndromes, but also cerebrovascular events. There's a definitely higher incidence of stroke and TIAs. So this is both a pathophysiological test, which tells you why the patient's got angina, and a vascular risk marker, and that needs to be managed.
There are 2 studies out there showing that patients with microvascular dysfunction have a different composition in epicardial plaque. So they have more vulnerable plaques when they have microvascular dysfunction compared to those with normal microvascular function. Because the question is always, if they have normal arteries and reduced CFR, what triggers the events, right? And these 2 studies, they suggest that there may be a higher risk for epicardial disease in the future.
And perhaps endothelial dysfunction is your common pathophysiological mechanism.
which is why it's so important, even in our algorithm that we provide in the consensus, addressing the risk factor management is so key. Treat the hypertension, treat the hypercholesterolemia, and lifestyle.
Good. So with this, I think that we have approaching just the end of the session. We have prepared some key learnings that perhaps we can share. Very simple. Hopefully, you will be the experience that Enrique and that Peter has shared with us has convinced you that in patients like this with chronic coronary syndromes, the intracoronary physiology performed at the time of invasive angiography is a great opportunity to really clarify what is the next step, either in terms of revascularization or in outlining what is causing this angina, ischemia in a patient who has apparently non-obstructive coronary arteries. The assessment of epicardial stenosis we've seen before is now feasible both with hyperemic and non-hyperemic indexes. This facilitates things a lot. I would also say that the disclosure of the existence of non-obstructive myocardial ischemia and also understanding the causative mechanism, structural vasomotor is key in formulating stratified treatment. This afternoon, there was a study presented here at EuroPCR where it was demonstrated that thermodilution, with bolus thermodilution, the techniques that we have seen, can be performed with intracoronary adenosine, and that the result with 200 micrograms of intracoronary adenosine are even better than with intravenous adenosine. And this obviously opens a new era, I believe, in terms of making it even simpler in the cath lab. You don't need to perform intravenous adenosine administration from this. So this is, so to speak, breaking news from EuroPCR 2023. But if you are interested, you can check this in the website. So with this, first of all, I thank you. We thank you to all of you for staying with us until the end of the day in EuroPCR today. And thank you, of course, to Peter, to Enrique, and to Divaka, on behalf also of Divaka. Thank you very much, and have a good evening.